Problems of the vascular system include disorders of the arteries, veins, and the lymphatic vessels. These problems can result in decreased perfusion to the peripheral tissue, causing ischemia. Patients often have pain and difficulties with mobility and taking part in activities of daily living. Education is a key part of management. Proper nutrition, smoking cessation of management. Proper nutrition, smoking cessation, and exercise are important health promotion behaviors. Following measures to promote safety, especially for those on anticoagulation therapy, is crucial. The aorta is the largest artery and supplies O2 and nutrients and blood to all vital organs. One of the most common problems affecting the aorta is localized outpouching or dilation of the vessel wall. Aneurysms occur in men more often than in women, and in whites more often than blacks. The incidence increase with age. Aneurysms may occur in more than one location. Aortic aneurysms may involve the aortic arch and thoracic and or abdominal aorta. Three-fourths of aortic aneurysms occur in the abdominal aorta and one-fourth in the thoracic aorta. Most abdominal aortic aneurysms, or triple A's as we call them, occur below the renal arteries. A variety of disorders are associated with aortic aneurysms. The main causes are classified as degenerative, congenital, mechanical, such as blunt force trauma, inflammatory, such as aortitis, or infections. This slide shows angiography showing a fusiform abdominal aortic aneurysm. Note the calcification of the aortic wall, that's where the arrows are, and the extension of the aneurysm to the common iliac arteries. Both aortic aneurysm and aortic dissection have a strong genetic component. The familial tendency is related to several congenital anomalies. Examples include bicuspid aortic valve, coarctation of the aorta, Turner syndrome, autosomal dominant polycystic kidney disease, specific collagen deficits, and premature breakdown of vascular elastic tissue, as is found in Marfan syndrome. Risk factors for aortic aneurysms include age, male gender, hypertension, coronary artery disease, family history, tobacco use, carotid artery disease, previous stroke, and obesity. Tobacco use is the most important modifiable risk factor. The larger the aneurysm, the greater the risk for rupture. Aneurysms are classified as true or false. A true aneurysm is one in which the wall of the artery forms the aneurysm with at least one vessel layer still. Picture A and B both show true aneurysms. C is a false aneurysm or a pseudoaneurysm. True aneurysms are subdivided into fistiform or saccular types. A fistiform aneurysm is circumferential and relatively uniform in shape. A saccular aneurysm is pouch-like with a narrow neck connecting the bulge to one side of the arterial wall. A false aneurysm or a pseudoaneurysm is not an aneurysm. It is a disruption of all arterial wall layers with bleeding that is contained by surrounding anatomical structures. False aneurysms may result from trauma, infection, peripheral artery bypass graft at the site of the graft to artery anastomosis, or arterial leakage from the removal of a cannula, such as a femoral arc catheters or an interaortic balloon pump device. Thoracic aortic aneurysms are often asymptomatic. When present, symptoms include deep diffuse chest pain that may to the intrascapular area. Ascending aortic and aortic arch aneurysms can cause, first, angina from decreased blood flow to the coronary arteries, second, transient ischemic attacks from decreased blood flow to the carotid arteries, and third, coughing, shortness of breath, hoarseness, and or difficulty swallowing from pressure on the laryngeal nerve. If the aneurysm presses on the superior vena cava, decreased venous return can result in jugular venous distension and edema to the face and arms. Triple A's are often asymptomatic. They are often found during routine physical examinations or evaluations for unrelated problems. A pulsatile slightly to the left of the midline may be present. Bruits may be auscultated over the aneurysm. Physical findings may be hard to detect on obese persons. AAA symptoms may mimic pain associated with abdominal or back disorders. Compression of nearby anatomical structures and nerves may cause symptoms such as back pain, epigastric discomfort, altered intermittent claudication. Sometimes aneurysms spontaneously embolize plaque, causing blue toe syndrome, which is patchy modeling of the feet and toes in the presence of palpable pedal pulses. Aneurysm rupture is the most serious complication. It is more likely to occur in people who smoke tobacco. If the rupture occurs in the retroperitoneal space, bleeding may be controlled by surrounding anatomical structures, preventing extravasation and death. In this case, the patient often has severe back pain. Back or flank ecchymosis, which is called Gray Turner's sign, may be present. If rupture occurs into the thoracic or abdominal cavity, the patient can die from massive hemorrhage. The patient who reaches the hospital will be in hypovolemic shock with tachycardia, hypotension, pale clammy skin, decreased urinary output, altered level of consciousness, and abdominal tenderness. For patients admitted to the hospital with a ruptured AAA, in-hospital mortality rate is high at about 50% of the thoracic aorta. An abdominal x-ray may show calcification of the aortic wall. An EKG may rule out MI since the thoracic aneurysm or dissection symptoms can mimic angina. Echocardiography assesses the function of the aortic valve. Ultrasound is useful for aneurysm screening and to monitor aneurysm size. A CT scan or an MRI can diagnose and assess the location and severity of the aneurysm. Angiography gives helpful information by using contrast imaging to map the entire aortic system. The main goal of interprofessional care is to prevent the rupture of an aneurysm. Early detection and prompt treatment are essential. Conservative medical therapy for small asymptomatic AAAs, less than 5.4 centimeters, is the best practice. This consists of risk factor modifications such as ceasing tobacco use, decreasing blood pressure, optimizing lipid profile, and gradually increasing physical activity. Hypertension, hyperlipidemia, diabetes, and other cardiovascular disease risk factors. A statin and an ACE inhibitor could prove to be beneficial. Those with small aneurysms, 4.0 to 5.4 centimeters, should have monitoring of aneurysm size using ultrasound or CT every 6 to 12 months. Ultrasound monitoring every 3 years is done for patients with AAA smaller than 4.0 centimeters in diameter. Surgical repair is recommended in patients with asymptomatic aneurysms 5.5 centimeters in diameter or larger. Surgical intervention may occur sooner if the patient has genetic disorders, if the aneurysm expands rapidly, or the patient becomes symptomatic, or the risk for rupture is high. A careful review of body systems is needed to identify any comorbidities as they affect the patient's surgical risk. Correcting existing carotid or coronary artery blockages may be needed before aneurysm repair. For elective aneurysm repair surgery, the patient is with normal electrolytes, coagulation, and hematocrit. If the aneurysm ruptures, emergent surgery is required. Open aneurysm repair, or OAR, involves a large abdominal incision through which the surgeon cuts through the diseased aortic segment, removes the thrombus or the plaque, sutures a synthetic graft to the aorta proximal and distal to the aneurysm, and sutures the native aorta wall around the graft to act as a protective cover. For iliac artery aneurysms, a bifurcation graft replaces the entire diseased segment. With sacral aneurysms, it may be possible to excise only the balloon lesion and repair the artery or applying an autogenous or synthetic patch graft. All OARs require aortic cross-clamping proximal and distal to the aneurysm. Most resections are done in 30 to 45 minutes, then the clamps are removed and blood flow is restored. The risk for postoperative complications, such as acute kidney injury, increases in patients who have an level of the renal arteries. This slide is a visual representation of the procedure I just described. A is the incision of the aneurysmal sac, B is insertion of the synthetic graft, C is the suturing of the native aortic wall over the synthetic graft. Minimally invasive endovascular aneurysm repair, or EVAR, is an alternative to OAR for select patients. Eligibility criteria involved iliofemoral vessels that allow for safe graft insertion and vessels of sufficient length and width to support the graft. EVAR involves the placement of a sutureless aortic graft in the abdominal aorta inside the aneurysm via the femoral artery. Grafts are made of various materials, such as a Dacron cylinder consisting of several sections and supported by multiple rings of flexible wire. This slide shows a bifurcated or two-branched endovascular stent grafting of an aneurysm. The main section of the graft is bifurcated. It's delivered through the femoral artery catheter. The second part of the graft is inserted from the opposite femoral artery. When all graft components are in place, they are deployed against the vessel wall by balloon inflation. So figure A shows the insertion of a woven polyester graft covered by a tubular metal web, which is your stent. Figure B shows the stent graft is Figure B shows the stent graft is inserted through the large blood vessel, the femoral artery, using a delivery catheter. The catheter is positioned below the renal arteries in the area of the aneurysm. In Figure C, the stent graft is slowly released into the blood vessel. When the stent comes in contact with the blood vessel, it expands to a preset size. Figure D shows inserted in the opposite vessel if needed, and then Figure E shows them fully deployed. The blood then flows through the endovascular graft, preventing further expansion of the aneurysm. Angiography is done afterwards to check for any leaks and to confirm patency of all stent graft components. The aneurysmal wall shrinks over time because the blood is diverted through AR and requires a shorter hospital stay. EVR also has fewer complications, such as paraplegia and death. The most common complication of triple air repair is endoleak, and that's the seepage of blood back into the old aneurysm. This may result from an inadequate seal at either graft end, a tear through the graft fabric, or leakage between overlapping graft segments. Repair may require coil embolization, which is the insertion of beads for homeostasis. Other complications include aneurysm growth above or below the graft, aneurysm rupture, aortic dissection, bleeding, renal artery occlusion migration, graft thrombosis, incisional site hematoma, and incisional infection. Patients undergoing EVAR need periodic imaging for the rest of their lives to monitor for an endoleak, document stability of the aneurysm sac, and to determine the need for surgical intervention. A potentially lethal complication of emergency repair of a AAA is the development of interabdominal hypertension, or IAH, with associated abdominal compartment syndrome. Persistent IAH reduces blood flow to the viscera. Abdominal compartment syndrome refers to the impaired organ perfusion caused by IAH and the resulting multisystem organ failure. IAH is confirmed by measuring the patient's intra-abdominal pressure indirectly through a catheter and transducer system. Treatment goals include control of situations that lead to IAH. Interventions include open or surgical decompression, percutaneous drainage, and percutaneous drainage combined with a thrombolytic infusion, such as intubation, ventilation, patient positioning, gastric decompression, cautious fluid resuscitation, pain management, and temporary hemofiltration are used. When we begin to think about nursing care, we want to start with assessment. We want to begin by performing a thorough history and physical assessment because atherosclerosis is a systemic disease, cerebral and lower extremity vascular problems. Monitor the patient for signs of aneurysm rupture. This includes diaphoresis, pallor, weakness, tachycardia, hypotension, abdominal, back, groin, or periumbilical pain, changes in level of consciousness, or pulsating abdominal mass. Establish baseline data to compare to later assessments. Pay special attention to the character and quality of the patient's peripheral pulses and renal and neurological status. Before surgery, mark the pedal pulses, both the dorsal pedis and the posterior tibial, with a single-use marker and document any skin lower extremities. Overall goals for the patient undergoing aortic surgery include normal tissue perfusion, intact motor and sensory function, and no complications related to surgical repair such as thrombus, infection, or rupture. To promote overall health, encourage the patient to reduce the cardiovascular disease risk factors, including controlling blood pressure, ceasing tobacco use, and maintaining normal body weight and serum lipid levels. These measures can help ensure continued graft patency after surgical repair. Counsel the patient about taking part in moderate physical activity. Before surgery, provide emotional support and teaching to the patient and the caregiver. Perioperative teaching includes a brief explanation of the disease process, the planned surgical procedure, preoperative routines, what to expect right after surgery in terms of the recovery room, the kinds of tubes, lines, and drains the patient might have, and usual postoperative timelines. Specific routines vary by agency and healthcare provider. Aortic surgery patients have a bowel preparation and skin cleansing with an antimicrobial agent the day before surgery, are NPO after midnight the day of surgery, and receive IV antibiotics before the incision is made. Patients with a history of cardiovascular disease should receive a beta blocker. Scheduling a preoperative visit to the ICU may be helpful. Patients typically go to the ICU for 24 to 48 hours for close monitoring. When the patient arrives in the ICU, various devices are in place. These include an endotracheal tube for mechanical ventilation, an arterial line, a central venous pressure or a CVP catheter, peripheral IV lines, and an indwelling urinary catheter, and possibly a nasogastric tube. The patient needs continuous ECG and pulse oximetry monitoring. If the thorax is open during surgery, chest tubes will be in place. The patient may have a lumbar catheter draining cerebrospinal fluid to prevent neurological deficits. Pain medication is given via subcutaneous infusion into sites, epidural catheters, or IV patient-controlled analgesia. In addition to the usual goals of care for a postoperative patient, such as maintaining adequate respiratory function, fluid and electrolyte balance, and pain control, we will check for graft patency and renal perfusion. Watch for and intervene to limit or treat cardiac ischemia, dysrhythmias, infection, venous thrombus emboli, and neurological complications. Acute post-op care focuses on several areas. We'll start with cardiovascular. In cardiovascular, we're going to continuously ECG monitor our patients. We're going to monitor their electrolytes. We're going to monitor their arterial blood gases. We're going to give them oxygen. We may be administering antidysrhythmics or antihypertensive meds. We'll do pain control, and we want to be sure and resume any of the patient's previous cardiac medications. In terms of caring for post-op infection, we want to give antibiotics, assess for a temperature, monitor WBCs, ensure the patient has adequate nutrition, observe the surgical incision for signs of infection, good hand hygiene and aseptic technique for all invasive procedures, and good pericare to decrease the risk of urinary tract infection. For GI status, we want to monitor for a paralytic ileus, which means we're listening for flatus, which is a return of bowel function. We want to record the amount and the character of the NG tube output if we have an NG tube. The patient will be NPO, so we want to provide oral care. We want to look at our abdominal assessment and assess for signs of bowel ischemia, absent bowel sounds, fever, abdominal distension, diarrhea, and bloody stools. Neurologically, we want to look at level of consciousness, pupil size in response to light, facial symmetry, speech, ability to move upper extremities, and the quality of hand grasps. If the aneurysm involved the descending aorta, we want to be sure and check the neurovascular status. Assessing pulses is one of the ways we monitor the ongoing status of our aneurysm repair. For our peripheral perfusion status, we want to frequently assess those pulses and use a Doppler if needed. We want to mark the pulse locations with a felt tip pin. If the aneurysm was at the ascending aorta or the aortic arch, we want to check the carotid, radial, and temporal pulses. If it's on the descending aorta, we want to check the femoral, popliteal, posterior tibial, and dorsal pedal pulses. Our extremity assessment is also important. We want to look at temperature, color, capillary refill, sensation, and movement of the extremities. We want to look for vasospasm and hypothermia, which is caused by an absence of lower extremity pulses. During assessment, if we find absent pulses and cool, pale, mottled, or painful extremity, it means there's an embolization or graft occlusion, and we want to report that immediately. Our renal perfusion status is also very important, so we want to do hourly urinary outputs. And an accurate INO, we want to do daily weights, check CVP pressures, check our BUN and creatinine. We want to look for decreased renal perfusion, which may occur if there's an embolization of plaque of the renal arteries, hypotension, or prolonged aortic clamping or blood loss. For ambulatory care, we want to teach the patient and irregular bowel patterns are common. Have the patient avoid lifting for 6 weeks after surgery. Report any redness, swelling, increased pain, drainage from the incisions, or fevers greater than 100 degrees Fahrenheit to the healthcare provider. Teach the patient and the caregiver to look for changes in color and warmth of the extremities. Patients and caregivers can learn to palpate peripheral pulses to assess changes in their quality. Sexual dysfunction in male patients is common after aortic surgery. A referral to a urologist and counseling may be useful if erectile dysfunction occurs. Our expected outcomes include patent arterial graft and adequate urinary output and no signs of infection. So from aneurysm, we're going to move to aortic dissection. Aortic dissection is classified based on the location of the dissection and duration of onset. Type A dissection affects the ascending aorta and arch and requiring emergency surgery. Type B dissection begins in the descending aorta, allowing for potential conservative management. We also describe dissections as acute, which is in the first 14 days, subacute, 14 to 90 days, or chronic, greater than 90 days, based on symptom onset. Aortic dissection, often misnamed dissecting aneurysm, is not a type of aneurysm. Rather than ballooning like an aneurysm, dissection results in the creation of a false lumen between the intima, which is the inner lining, and the media, the middle layer of the arterial wall. This slide in picture D shows you a picture of an aortic. This slide is actually a picture of a dissection on the descending aorta. You can see the heart, the kidneys, and the dissection area. In discussing the etiology and pathophysiology, we're looking at non-traumatic aortic dissection. It's due to weakened elastic fibers in the arterial wall. Chronic hypertension hastens the process. They're in the middle layer. Rupture through outside walls can cause death. As the heart contracts, each systolic pulsation increases pressure on the damaged area, making it worse. It may occlude major branches of the aorta, cutting off the blood supply to the brain, abdominal organs, kidneys, spinal cord, and extremities. False lumen may remain patent, becoming thrombosed or rejoining the true lumen. This affects men more than women. Women with aortic dissection are often older and have heart failure, coma, or altered mental status. Hypertension is one of the most important risk factors. Other predisposing factors are age, aortic disease, tobacco use, cocaine or methamphetamine use, congenital heart disease, connective tissue disease, family history, previous heart surgery, and pregnancy. About 80% of patients with acute type A aortic dissensions report an abrupt onset of severe anterior chest or back pain. Patients with acute type B aortic dissections are more likely to report pain in their back, abdomen, or legs. Pain location may overlap between type A and type B dissections. The pain may be described as sharp and worst ever, or as tearing, ripping, or stabbing. Dissection pain can be distinguished from MI pain, which is more gradual in onset and has increasing intensity. As the dissection progresses, pain may follow the path of the dissection. Older patients are less likely to have an abrupt onset of pain and more likely to have hypotension and vague symptoms. Some patients have painless aortic dissection, emphasizing the importance of physical examination. If the aortic arch is involved, the patient may have neurological deficits. These include altered level of consciousness, weakness or absence of carotid or temporal pulses, dizziness, or syncope. Type A aortic dissection usually disrupts blood flow to the coronary arteries and causes aortic valve insufficiency. When either subclavian pressure readings may be different from the left to the right arms. As the dissection progresses from the aorta, the abdominal organs and lower extremities may show signs of decreased tissue perfusion. A severe and life-threatening complication of an acute ascending aortic dissection is cardiac tamponade. This occurs when the blood from the dissection leaks into the pericardial sac. Manifestations of tamponade include hypotension, narrow pulse pressure, jugular vein distension, muffled heart sounds, and pulsus paradoxus. An aorta weakened by dissection may rupture. Hemorrhage may occur in the mediastinal, pleural, or abdominal cavity, results in extravasation and death. Aortic dissection can lead to occlusion of the blood supply to vital organs. Spinal cord ischemia can lead to weakness and decreased sensation, and rarely to complete lower extremity paralysis. Renal ischemia can lead to renal failure. Abdominal or mesenteric ischemia can occur and result in abdominal pain, decreased bowel sounds, altered bowel function, and bowel necrosis. Diagnostic studies to detect aortic dissection are similar to those for suspected aneurysms. An ECG may help rule out cardiac ischemia. A chest X-ray may show a widening of the mediastinum and pleural effusion. MRI, 3D CT scanning, and transesophageal echocardiogram, or TEEs, are equally reliable for the diagnosis of acute aortic dissection. A CT scan or MRI can give more detailed information on the severity of the dissection and related complications, such as pericardial effusions or carotid dissections.
TEE is preferred in very unstable patients or those with contraindications for CT or MRI, such as those with metal implants or allergies to contrast media. Patients with acute aortic dissections are managed in the ICU. The initial goals of therapy for acute aortic dissection without complications are heart rate and blood pressure control, reduces aortic wall stress by decreasing systolic blood pressure and myocardial contractility. An IV beta blocker is titrated to target the heart rate at 60 beats per minute or a systolic blood pressure between 100 and 110 millimeters per hemoglobin. A calcium channel blocker such as diltiazem can be used to lower heart rate if a beta blocker is contraindicated. Reducing the heart rate, blood pressure, and myocardial contractility limits the extension of the dissection. Morphine decreases systemic nervous system stimulation and relieves pain. Supportive treatment for an acute aortic dissection serves as a bridge to surgery. The patient with an acute or chronic can be treated conservatively. Conservative treatment includes pain relief, heart rate and blood pressure control, and cardiovascular risk factor modification with close surveillance imaging with CT or MRI. Endovascular repair is a treatment option for acute type B aortic dissections with complications such as hemodynamic instability and chronic type B aortic dissections with complications, for instance, peripheral ischemia. Thoracic endovascular aortic repair, or a TEVAR, is similar to an EVAR. Fewer post-surgical complications occur with TEVAR. However, TEVAR does not prevent the risk for renal failure, paraplegia, or stroke. A lumbar spinal drain may be inserted to help decrease or prevent neurological complications. If a lumbar drain is used, strict aseptic technique is essential to prevent infection. Type A aortic dissection is a surgical emergency. Mortality rate is 50% within 48 hours of symptom onset. Otherwise, surgery is indicated when conservative therapy is ineffective or when complications occur. Open surgical repair is recommended for patients with a chronic dissection who have a connective tissue disorder or an aneurysm greater than 5.5 centimeters. The aorta is fragile after dissection. Surgery is delayed when possible to allow time for edema to decrease and to resection of the aortic segment with the intimal tear and replacing with a synthetic graft. Even with prompt surgical intervention, the in-hospital mortality rate is high. Causes of death include aortic rupture, mesenteric ischemia, MI, sepsis, stroke, and multi-organ failure. Preoperative and multi-organ failure. Preoperative nursing care includes keeping the patient in bed in a semi-Fowler's position and maintaining a quiet environment. These measures help keep the heart rate and systolic blood pressure at the lowest possible level that maintains vital organ perfusion, typically a heart rate less than 60 beats per minute and a systolic blood pressure between 100 and 100. Be sure and give the opioids and sedatives as ordered. We want to manage pain and anxiety because they can cause elevations in heart rate and systolic blood pressure. Titrating IV antihypertensive agents requires careful supervision, including continuous ECG and arterial blood pressure monitoring. Monitor vital signs frequently, sometimes as often as every 2 to 3 minutes, until target heart rate and blood pressure are reached. Look for changes in peripheral pulses and signs of increased pain, restlessness, and anxiety. Postoperative care is similar to that after OAR. In preparation for discharge, focus on patient and caregiver teaching. All patients with a history of aortic dissection require long-term health care to control heart rate and blood pressure. Help patients understand that they need to take antihypertensive drugs daily for the rest of their lives. Beta blockers are used to control heart rate and blood pressure and decrease myocardial contractility. ACE inhibitors are given if the patient cannot tolerate beta blockers. It's important that the patient understand the drug regimen and side effects, such as dizziness, depression, fatigue, and erectile dysfunction. Tell the patient to discuss any side effects with the healthcare provider before stopping any medications. Follow up with regularly scheduled MRIs or CTs is essential. The most common cause of death in long-term survivors is aortic rupture from redissection or aneurysm formation. Return, they should activate the emergency response system for immediate care.